uterine artery flows are normal, that means that the IUGR is coming within the placenta and the fetal unit. Okay. So reasons like we do that, if there was a bad outcome, then we can test all those things and actually know why, and we can give better recommendations for a future pregnancy. So the uterine artery, we've got 3 different flow styles here. So we've got a systolic peak, a diastolic level, and that little peak just in here, up at the top where the arrow is, that's the last point of the heart relaxation before it contracts again up to the systolic. So a notch in here is not what we want to see on the arteries. So the presence of notching after 22 weeks is associated with several other conditions with potential adverse outcomes. So these include hypertension, PET, abruption, IUGR, and increased maternal serum alpha-fetoprotein. That is a mouthful. So while notching can either be systolic or diastolic, it's typically seen as a trough, like we can see up there, in between the phases. So the presence of a notch late in pregnancy is an indicator of increased uterine vascular resistance and impede circulation to the baby. So the middle cerebral artery, so that is the artery that we saw on the baby that's in the brain. Oh, thank you. That. Good. So this value is normally quite high. The normal reference range slowly decreases with gestation from around 28 weeks. A low PI reflects redistribution of cardiac output to the brain due to the fetal head sparing theory. So that theory is one that underpins asymmetrical intrauterine growth, when there's a difference between the HC and the AC. So the head becomes bigger because the blood supply to the brain is taken precedence over the rest of the body. Does that make sense? Yeah. So slowly, as all the oxygen goes to the brain, the heart will eventually become quite hypoxic as well, and that will begin to shut down and can have long-term effects onto the heart. So another test, if the MCA is abnormal, we can do the CPR, which is the cerebroplacental ratio. It's used as another predictor for outcomes, and it's calculated by dividing the PI of the MCA by the umbilical artery. Yeah, I've actually got that in here as well. This index will reflect an increase in placental resistance with reductions in the fetal brain vascular resistance. So we're going to go back to basics, and we're going to think about our basic fetal circulation. We've got the ductus venosus. Hopefully you remember where that is. Coming up here. That comes from the umbilical vein going into the right side of the heart, and that accounts for about 40% of the blood going into the ductus venosus, and 98% of that is oxygenated, so that's going straight to the heart.
Mum, doing that.
Oh, in a minute. So if the flow there is abnormal, or the Doppler flow is abnormal, that means that that side of the heart isn't getting the oxygen it needs, and it can lead to compromised fetal cardiac dysfunction. Last little test we can do, we do this one quite often, I've seen in DAU, is the peak systolic velocity of the middle cerebral artery. Quite frequently done when we've got known antibodies in the mum. So what happens when there is isoimmunization, maternal antibodies can get into the fetal circulation, which can cause hemolysis and fetal anemia, which can lead on to hydrops fetalis. I think that's the right way you say it. So with anemia, the blood is less viscous and therefore flows at a higher velocity. The peak systolic velocity of the middle cerebral artery correlates with the degree of anemia, thus increased velocity with worsening anemia. So we would see, hey, what have you done? We would be seeing that figure go up. So we've actually seen this one woman in DAU at the moment who's got A, little b, and D, I think, and she had her last delivery at 39 weeks, and Kirsten's waiting for the baby was severely IUGR. She's waiting for that one, she's been screening her about 3 times a week. It's fascinating waiting for this baby to eat its perch. Yes. So, resources. I had lots of fun online figuring out what resources were good and understandable to use. So, the best one, this one's quite medical, is the Ranscock Fetal Surveillance Education Program, which is all free. You can download this workbook off the website, and it can give you, if you really want to get into looking at the waveforms, it gives you videos of what waveforms are on it and a really good little blurb about what each one does and why we do it. Hopefully in a more sophisticated way than what I have. The next one that has all of our reference guidelines is the New Zealand Obstetric Doctor Guideline. And this also has all of our reference charts in it as well. And this is what we use in antenatal clinic and DAU. And it gives you all the indications for each one. We also have our lovely New Zealand College of Midwives assessment in pregnancy, which has given us our basic identifications of what's normal and what's abnormal and what we need to do. And lovely Jill Knight has updated our fetal surveillance guideline, which is almost due to be redone. So that's also giving us, for our unit, guidelines for what we need to be doing. What's that? Does anyone have any questions?
That fetal surveillance, the first one you referred to, the first resource, is that the one you do before the fetal surveillance workshop?
No, that's a CTG workshop. So this is all about fetal placental dopplers. So it's another little module that they've got on the website.
It's the same website, it's just a different module.
Yeah, so they've got lots of different little learning programs that you can do on there. It's really interesting.
Rachel, when should, so you said some of the indications for dopplers that need to be done, when should we be actually kind of ordering dopplers? Because I had a woman that had some oligo, and we were just sort of keeping an eye on what the AFIs and stuff were.
Yeah.
And then it one said to me, oh, well, did you order dopplers? I'm like, no, I didn't know I should be, could do whatever.
So I mean, general routine practice would be like you do your growth chart and you're plotting your fundal synthesis height. If there's any deviations from that, and you refer for a growth scan, if that is showing something that you need to be concerned about, I would then be requesting further lipo volume and Doppler values.
I think that she was rescanned for a low lipo placenta at 31 weeks or something, but then showed up the low lipo, so then it was from that I reviewed it, and she was, I can't even remember what the whole process was now. But yeah, it was just something that he said, it was like, did you order Dopplers? And I'm like,
I think if there's any concern within the fetal unit, you can be ordering Dopplers.
So we can do that. And you just put on there, just fetal Dopplers on the next scan that you see.
And they will report on them usually if they're abnormal. Or they'll just comment that they're normal.
Is that not automatically done with the growth scan?
No.
I wonder though, if in the community, if we're seeing women and we're monitoring and the growth is on, and then we do a scan and that's off as well, should we be referring?
Yes.
I think I consulted because of the low lipo and just rescan her in a couple of weeks or something, and it's still low. And when I spoke to Ikman about it, he said, did you order Dopplers? And I was like, well, no, because the Reg didn't say to order Dopplers, so she just intended for a scan. And I was like, is that something I should have actually, because we didn't have that information.
Are you sure you want Dopplers on every growth scan?
No, if there's an issue with the growth, then I would be requesting Dopplers. I mean, if you've got someone who's got an abnormal growth scan, you'll be sending them in for a referral anyway, either to clinic or an acute assessment. They can then make a plan whether they want Dopplers done. The good thing about Dopplers is they can be done more frequently than growth scans. So growth scans you wouldn't do a minimum of more than 2 weeks apart, but lipo and Dopplers you can do twice a week, 3 times a week if you need to.
Are they done bedside as well?
They can be if it's needed, but it's better to make a formal assessment. Yeah.
So on a first port of call though, as an LMC, you would be doing a growth scan.
Yes.
And then I think you were right.
I mean,
because you didn't have any indication.
I guess the pain in the whole thing was that by the time we had the second scan done, because of the low light from the first one, as ordered by the reg, who didn't say add dopplers to it, then it's like, now what do we do? And they were sort of saying, oh, only good if we had that information.
If they want that, just send it for another scan to get like a done. But I mean, if you've got a baby with like any of these, and you're sending her for a